better. Well, hello and welcome to the 27 Degree with Chris and Nancy, being broadcast from the BioSkills of Northeast Studio in Fall River, Massachusetts. And today we'll be discussing orthopedic surgery with Dr. Jay Patel. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. So, thank you so much for coming in today. We appreciate it, and I'm really excited to hear what you have to say about some of the newer techniques in orthopedic surgery. But before we get going, why don't you just tell our audience a little bit about you, your background, and we'll start there.
Yeah, so thank you for having me. My name's Jay Patel. I'm an orthopedic surgeon. I did a fellowship in hip and knee replacement, and then one in orthopedic oncology. I'm originally from New York City, Queens, New York. And I did most of my schooling there and training in New Jersey and California before coming up here.
That's great. A lot of training, a lot of time to be an orthopedic surgeon.
14 years about.
14 years,
give or take.
Yeah.
What interested you about orthopedic surgery? Like when you were in school, you're like, oh, this is really cool. I like
what was
this.
it that you put you in that direction versus something else?
So I liked it because, there was you can pinpoint a certain problem and then fix it right away versus other times, if the patient has high blood pressure, you give them medicine, but you can't really see those results, visibly at least.
Yeah, you don't see it visibly.
So it's a bit gratifying in that regard where you can see, the fruits of your labor or your work in orthopedic surgery.
Right.
Now, when patients go to you, and you specialize mainly in knees and hips, is
yes.
that correct? Doing a lot of that surgery, like much more surgery now than a few years ago, or about the same?
No, so doing more now
Yeah.
than, a few years ago.
Nice. So when people see you for like a knee or a hip, are they they're done with all the other alternatives?
I have both types of patients where someone is brand new, they haven't tried anything, and they come in with knee pain for the last few years, they've just been putting it off.
Yeah.
And then I have other patients where they've seen their primary care doctor or somebody else, and they've had injections and other things, and nothing's working, so they come straight to surgery, for surgery to see me.
So there's some that you see more on a consultative basis for, say, knee pain or hip pain, and it's not clear that they would require surgery yet.
Right.
But you're seeing them and giving them options.
Right.
And then others, it's pretty clear that they have advanced disease and they're sent over for surgery.
Right. So in both types of patients, and the ones that are brand new that haven't tried anything, I typically don't like to recommend surgery to anybody. I like the patient to make that decision where, I think I'm ready to have surgery now.
Yeah.
So we try things, and informing them that, listen, this is not a cure. Injections, medications, physical therapy can help your pain. Ultimately, at some point in the future, you might need surgery, but otherwise, and so they go through the progression of those treatments, and some do well for a few years, they get by, and then eventually they come to a point where they're like, you know what, I think I need surgery now.
Yeah.
So what diagnostically do you see where you're like, oh yeah, it's time for surgery now?
So we typically look at x-rays, or MRIs. On x-ray, you can see the space between the two bones just worn away and the bones are just rubbing on each other.
That's it, bone to bone.
But more importantly than that, we look at the patient because on x-rays, some people come in with terrible arthritis, but they're like, I don't have any pain at all. So we don't typically do surgery on those patients because, they're otherwise fine. And the patients that have really bad arthritis and they're in pain, those are the ones that we do surgery on because we can make those patients better.
Right.
So the patients that aren't feeling any pain, it's okay for them, even though their x-ray might be telling a different story, as long as they're not feeling pain, it's okay for them to hold off?
Most of the time, yes.
Do they make things worse by kind of holding off? Or
no, I mean,
you can tell that and you can
so I tell them, you can't stop living your life. You have to, work, do whatever you have to do, kids, hobbies, things like that. But so you can't really damage it because the joint's already worn away,
Okay.
you know.
All right, that's a good way of putting it. Now, like, what's the age span? Like, the majority of your patients going in for knees are kind of like circling around what age versus, and don't say my age, and circling around like their hips are like kind of what age, or is
Meaning,
it just
is it the same age group?
yeah, or is it
They're
you
both-
know someone like maybe who's a jogger you might see more degeneration and
So they're both similar age groups. We typically see anybody. I've done hip or knee replacement in teens for cancer or other reasons, in people in their 20s because they have rheumatoid arthritis that was never diagnosed.
okay.
And by the time, their late 20s, their joints are already completely worn away and they've tried everything. I had one patient, she was 26 and she was in a wheelchair and crutches. So I was like,
Really?
you're 26, but your hips are 80 or 90. So
Wow.
Right.
we replaced both her hips and then she was
So
fine.
you gave her like a new lease on life. That one.
Yes.
Nice.
And then we have the other end where patients are in their 80s,
Yeah.
some in their 90s. But typically, I would say on average, patients are in their 60s.
Okay.
And that number is getting younger and younger.
Why?
And that's the majority of what you see, I would think, for joint replacements, the osteoarthritis patients,
Right.
the wear and tear over time.
Yes.
So why do you think it's getting younger? Is it because of weight gain, obesity in our population? What's the reason that
I
you're
think-
seeing people needing joint replacement at younger ages from osteoarthritis?
I think it's due to a couple of factors. One is surgeons are now doing surgery on younger patients.
Okay.
Before, if you were 50 and your knees were completely gone, they'd say come back when you're 70, 75 because technology has advanced where before the knee replacements lasted maybe 10 years.
Right.
Now they can last maybe 20 years,
Okay.
potentially 25 years,
That's
give or
great.
take. So
Yeah.
because of that, we can do it in younger patients.
Okay.
And we tell younger patients, like, listen, we're doing a knee replacement now. In 20 years, you might have to have it redone because it may wear out, so they understand that. And in certain patients, we say, let's try to prolong it with injections and other things so we can
Right.
get you to an age where you might only need one other surgery in your life.
Nice.
That's interesting. Okay.
Is it the same for the hips? Do they last like 20 to 25 years too?
Yeah, a well-done hip or knee should last on average about 20 years. Some people 25. You see some in their 30s as well.
Why are they lasting longer? Is it a different product that's available now? And is it different materials or the way it's designed? I'm wondering if it's actually the material itself or the design of the hip or knee that is making it last longer than it did years prior.
So hip and knee replacements have knee replacements have two metal components, and in between the two is a plastic component made out of polyethylene,
Okay.
which is like a type of plastic. But over time, they've improved that design and structure,
Okay.
so it wears out a lot slower than before.
Okay.
So if it's like cars on a tire where the tires may wear out in like 10,000 miles or 20,000 miles. They tell you to change your tires. So in 20 years, as long as the metal is fine, then they can go in, take out the plastic liner, and put in a new
I
one.
was wondering that because I always see I see the people. It seems they're having just complete revisions, right? But you can actually take that liner out, and
As long as the metal is not loose,
Yeah,
and there's
that's
tests
great.
we do for that,
that's great.
so you can do that. But what happens is typically patients, they're wearing away, and they kind of ignore the pain until
Yeah.
it gets debilitating.
And it
But
gets to the metal.
right, and then your body, as a plastic wears away, your body eats up those little pieces, and it causes inflammatory reaction, and that causes the metal and
Oh,
bone to
sure.
loosen over time.
Interesting.
Right.
I always wondered how that happened.
Yeah.
Interesting. So what are some of the telltale signs that a patient may have that they need a knee replacement or a hip replacement that you could talk to our audience about?
So I would say the number one is pain. And not pain like I have pain maybe once a week or once in a while. Pain maybe 5, 6, 7 days of the week.
Yeah, pretty constant.
Yes, yeah, constant pain. I have patients that say they can't walk to their mailbox anymore, they can't walk their dog anymore, or
A lot of limitation in function.
right. Because patients are like, my pain's not 10 out of 10, but I can't walk my dog anymore, or I can't golf or do hobbies anymore.
Yeah. Is this pain keeping them up at night, or is it more with activity?
Both. It can keep you up at night as well. Patients have trouble sleeping, or they say it hurts. There's the old wives' tale of, my knee hurts, it's going to rain today, which is true, or cold weather can make it worse as well.
That's interesting about the whole rain thing, because patients tell me that all the time, that that they know that
It's true.
and what is the science behind that?
They're not sure, but it has to do with the atmospheric pressure
Yeah.
and the humidity. So some people get like aching pain a few hours before it's going to rain. They know.
So fascinating.
So when your patient needs like a hip replacement or a knee replacement, we're talking about both of them. I'm sure there's very different things you're looking for with a knee versus like a hip. Is it usually just one knee they need, or is it both knees? And if it is both knees, are you doing them together or doing them one at a time?
So we have both, where some people have both bad knees.
Yeah.
Because some of arthritis is genetic.
Right.
You know, they're like, oh, my parents had it, my siblings, they all have replacements.
Yeah.
So some of it's genetic, so they may have both sides. Some people get it just from wear and tear on one side versus the other, or from an accident they had many years ago where they broke a
Right.
bone and now they have arthritis. But when we do surgery, we typically do one at a time.
Okay.
I like to space them out. I leave it up to the patient. Some people want it done right after the other, so maybe 8 weeks later or 10 weeks later.
Okay.
Other people are like, I'll come back in a year and have the other side done. But we typically don't do both at the same time.
Okay.
It's a bit harder recovery because you don't have any good leg to stand on.
Of course.
And there's more blood loss and other things associated with it. So sometimes you get like the rare patient where they're young, healthy, no other issues, in great shape. You can consider it, but typically it's one at a time.
So then pre-op, like when you're dealing with a patient, you're like, yep, we're headed into surgery and here's your dates in like 4 weeks, say, making that up. Do you want them to do anything specific, like pre-operatively going into the surgery?
So there's a lot patients can do.
Okay.
They say, you know, like you said, if you have to wait 6 weeks from now to your surgery date,
Yeah.
there's one doctor, Dr. Wickline, he likes to throw these numbers where he says it's about 1,000 hours, a little more. So you have 1,000 hours to get prepared or in shape. Surgery itself is on average less than an hour, 45 minutes sometimes up to an hour. So let's say an hour. And then recovery afterwards is about, by 12 weeks, I tell people you'll be pretty good, but full recovery can take up to 1 or 2 years. So your knee will keep getting better or stronger as long as you do the exercise up to a year out. But at 3 months, from surgery, that's about another 2,000 hours. So the surgery itself is a very small part of that 3,000 hours that you have.
Why is it so long
Recovery.
to get full recovery?
So there's a couple of reasons. One is your body has to get used to the new joint.
Okay.
Because some people, if you look at their legs, they may be bow-legged or knock-kneed, so then when you straighten them out, their body has to get used to that new positioning. The other thing is, I tell patients, we can only replace your joint. All your muscles, ligaments, tendons are going to be the same old ones from before.
Okay.
So if they're not used to walking this much or exercising or stretching, then you're going to have a tougher time with recovery, because you can't just get up off the couch and run a marathon, for example.
Right.
You have to train and get in shape. So one of the things they can do before surgery, like you were asking, is either physical therapy or exercises. Even if they do
Makes
15,
sense.
20 minutes a day.
Right.
And it doesn't have to be anything crazy, because obviously they have pain, but they can do chair yoga, or there's certain exercises they can do just laying down flat.
Yeah.
Anything to help get the muscles used to moving and stretching. Then nutrition's another big, important factor as well. There's a lot of studies now that show an anti-inflammatory diet can help you with healing around the time of surgery.
What's that anti-inflammatory diet?
They say it's like more of like a Mediterranean diet in terms of like, vegetables, berries, nuts, things like that. Not processed foods, fresh foods more. So
Of course.
there's another saying where they say like garbage in, garbage out. So if you're just eating processed foods or fast food all the time,
Right.
your body is not in the best shape that it could be.
Right.
Dr. Patel, do the patients still have that big scar nowadays when you do the knee surgery?
So our knee patients, on average, the scar is maybe about 5 inches.
Okay.
And, we'll go into it after, but our scar is also off to the side. So it's a bit different how I do knee replacement surgery versus some other people.
How come?
And then, so with the knee replacement, I do what's called the Jiffy knee. So
Okay.
it's a muscle sparing approach. So typically when you have knee replacement, they cut through your quadriceps tendon right above your kneecap. And then after surgery, they sew it back up and it has to heal. With this way, we go under the muscle, so we don't cut any muscles. So it's less pain, swelling, a bit of a quicker recovery.
Sign me up for that.
Yes, because the muscles don't
Right.
have to heal. They were never cut.
Exactly.
So that incision is off to the side. And then with our hips, the incision's about 8 centimeters,
Okay.
so not too big.
Little.
Yeah.
Yeah. Yeah.
So let's start with the knee. So this is a procedure that is, in this area, I think is fairly new. Am I right?
Correct.
Okay. So previously, what I saw was there'd be this big incision anteriorly in the front of the knee, and like you said, it cuts right through some of the major muscle
Right.
that is required for someone to recover and be able to, function normally, so that the recovery can be longer. And what I've always seen is that knees take a long time to recover, more than hips. And I don't know if you agree with that, but I see them on the rehab end, and it always seems to me the hip patients recover quicker than the knees, and maybe that's because of the fact that, as you mentioned, there's a lot of muscle damage. I don't know if that's the right word, but with the procedure, do you find that too, that the knees take a little longer?
I used to, and now it's the opposite,
Now
where
it's the
our knee
opposite
patients,
because you have this new procedure.
right, where our knee patients do, our hip patients do very well.
Yeah.
Our knee patients do even better.
So that's exciting to me, because I always found the knee patients had a tough time with this newer procedure. What is the recovery like compared to the way it was if you were to look at previous recovery versus the newer procedure?
So I would say with the newer procedure, it's about maybe, and everyone's different, but on average, 4 to 6 weeks quicker.
Oh, wow.
In terms of,
Big.
right, especially if you're trying to get back to work
Sure.
or you have kids or other things going on in your life. So, every week counts. But in terms of their physical therapy progress, they're about 4 to 6 weeks quicker in terms of their bending, walking ability, getting rid of their walker and cane. And the reason I think why knees sometimes, are slower than hips, one is there's a lot more swelling because the knee is very superficial compared to the hip, which is deep in there.
Right, right.
So that has, a lot to do with it. Also, the forces on the hip and knee are different.
Okay.
And then just the way the joints move as well.
The ligaments that are there around the knee, are they all preserved with a knee replacement?
So typically, a lot of patients ask, I have a meniscus tear or an ACL tear, can I get knee replacement? So we do cut out the meniscus, which are just the cushion between the two bones,
Yeah.
and the ACL.
Okay.
Your MCL, LCL, and in most cases your PCL we keep.
But the ACL, you have to
Right, we
ligate
remove.
or sever, I should say.
Yeah.
Interesting. Okay. Does that affect the stability of the knee?
So the design of the knee replacement replaces the function of the
Okay.
meniscus and the ACL.
Okay.
But your MCL and LCL we keep because you don't want your knee to wobble. So
Sure.
standard knee replacements don't account for that. So we have to keep those ligaments.
Okay. That's fascinating. So with this newer procedure, you're basically, instead of doing that big incision through the quadricep, you're going in. Is it lateral? Like to the
Medial,
side? Medial
on the
So
inside
medial.
of your
So you
thigh.
go
and
on the
knee.
inside, and you're actually going underneath the muscle.
Right,
So you're not, that muscle's not getting damaged or.
cut or anything.
Cut.
Yeah.
Oh, that's fascinating.
Dr. Patel, if you're like in your 50s and you leave a very active lifestyle and you're golfing and playing pickleball and doing all this great stuff, how long does it take you to get back to that activity level for, I know that's kind of like all over the spectrum, right? But just for like that average kind of athletic middle-aged person.
So typically for golf, for example, you can go back at maybe 4 weeks or 6
Okay.
weeks. You may not be able to walk, 18 holes, but you
Yeah.
can sit in a cart, golf.
Yeah, that's great.
I have patients that say they can play 18 holes. They're sore at the end of it, but
Yeah.
they can do it. So physically they can do it. Whether or not they have pain or little pain
Okay.
is a different story, but usually 4 to 6 weeks for golf.
Okay.
Pickleball may take a few weeks longer because there's a lot of side-to-side movements.
Exactly.
Golf is a bit more stationary.
Yeah.
But biking people can do. Running can take several months to be able to do. I had one patient, she's a professional runner. It took her about 8 months to get back to her level of running
Okay.
in competitions, things like that.
Of course.
And it's okay to run with a knee replacement?
It's
Doesn't it wear the joint out quickly?
Yeah, so I tell patients, listen, you can run if you want, just know that it may not last as long as
Yeah.
if you didn't run. But the goal of the knee replacement, one, is for you to be pain-free, but two, is for you to get back to your life.
Sure,
So as long as you understand, like, listen,
Yeah.
I'm okay if it doesn't last 30 years, let's say it lasts 15 years, then that's fine, as long as I get to run.
Okay.
So in talking about the knee, you talked a little bit about how replacements now are a little bit different, like just the way they look and the way they function than they were years back. But what's kind of coming out new that's maybe exciting that you're seeing? Is there like anything like on the horizon for like a knee replacement surgery?
So there's a few things around hip and knee replacement.
Okay.
One is the recovery protocol and things. So there's medications and things that help patients feel less pain, get back quicker, have less swelling.
Okay.
So that's exciting, for patients as well.
Of course.
And then there's, some surgeons use robotics or navigation to help them with surgeries, or in complex cases that can also be a valuable tool.
Yeah.
Because the number of hip and knee replacements done every year in the U.S. around the world is rising, and eventually they'll have to be revised at some point. So that number is also going to spike up as well.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
What are the main components that, like, when you're looking at a patient and you're like, all right, this is what you have to do to have the optimal recovery and like to feel good, and like, what are those components? Like, what do they have to be compliant with?
After surgery, you mean?
After surgery, yes.
Typically, you have to do physical therapy or exercises, something, whether you do it in physical therapy or some patients do it on their own at home that are just motivated. They're like, you tell me what to do, I'll do it. So we give them an exercise guide, but you have to be willing to do those, 3, 4, 5 days a week. Otherwise, you won't recover, and then there's no benefit of doing the surgery in you. So one is you have to be willing to do the surgery, to do the physical therapy or the rehab required after.
Yeah.
And two is you're not going to get better overnight. It's going to take you several months, to feel better. So at 3 months, you may be back at work, but you may get some aches and pains every now and then, or if you overdo it, you'll know. So, you just have to have a bit of a patience as well.
Yeah.
If for patients that smoke, for example,
ask about that.
yeah, that's kind of like a hard stop for a lot of surgeons for elective hip and knee replacement, because smoking decreases blood flow. It constricts the blood vessels, and so your skin won't heal, or you have higher incidence of infection. Also, the implants, the way they typically work is the bone grows into, they have like tiny holes.
Okay.
So the bone grows into it over the course of the first 6 to 8 weeks. So if you smoke, that may not happen. So the implant may become loose, and then you might need to have it redone.
Okay.
So a lot of hospitals and facilities, as well as surgeons, have a cutoff of, no smoking. So patients, we typically ask them to stop smoking about 6 weeks before and for 6 weeks after until the skin is all healed. So it's about a 2-3 month period. A lot of patients after that, they're like, I'm just not going to go back to smoking.
Of course.
12 weeks, why not just?
Yes,
right?
yeah.
Yeah,
And,
right.
Financially, it's a big help as well, not
Huge.
smoking. So,
Yeah, right.
and the other thing is if you have diabetes,
Yeah.
getting that controlled can help, because if your sugars are very high, there's a higher risk for infection. Infection is something that we take very seriously with hip and knee replacement, because if you get an infection, you can't just take a few antibiotics and get better. If you have an infection, it requires surgery, sometimes multiple surgeries, and then IV antibiotics followed by months of oral antibiotics. So it's a whole big process, because if you have an infected knee, for example, if you catch it within the first 3 or 4 weeks, sometimes up to 6 weeks, but within the first 4 weeks, you can go in, wash out the knee joint, and then the plastic part, you put in a new one.
Yeah.
Because there's not a lot of good blood penetration. So if you give antibiotics, they may not necessarily get delivered into the joint itself.
Okay.
There is some, but not in high concentration. So you have to go in and physically wash it out. If you catch it later, like after the first 3-4 weeks of symptoms, then the bacteria form what's called a biofilm. So they form like a protective layer on the metal and the plastic. So antibiotics and nothing can penetrate it. So then at that point you have to go in and take all the metal and everything out. Right.
I've had a couple patients who required that. It was just devastating. They had to have a spacer put in their knee.
for like 6 weeks or
Yeah,
a few
so
months at
you
least.
can't bend the knee, and
Yeah.
it's terrible.
Sounds
And
miserable.
then you need another surgery to go back and take that out and put in a new knee again,
Right.
you know.
It's not.
And then the more times you go in there, there's a higher risk for infection or something going wrong, you know. So,
Exactly.
so that's why we tell patients, like, listen, smoking is a big no. Diabetes, especially now there's so many medications for diabetes, you can better control it. Before
course.
there may not have been. So,
Yeah.
and then sometimes, weight loss can help as well.
Okay.
Because losing weight can, one, help control your sugars better. It can help decrease your blood pressure, So there's other benefits to that. You don't have to be, the perfect weight, but there a lot of places have a BMI cutoff of like 40. Some places 45 or
Okay.
even 50 in the South.
Okay.
Wow.
So
50, that's pretty
Yeah.
generous.
Yes, yeah.
Yeah.
So then, with the definite no-nos, we talked a little bit about the smoking and having the diabetes under control. But is there anything like some post-op patients will do that make you cringe and you're like, no, like, don't, why did you do that?
So one thing is we tell patients not to take a bath or go in a swimming pool for the first 6 weeks until your skin is fully healed.
Yeah.
Because,
yeah.
things can get in and cause
Yes,
an
of
infection.
course.
So there is that. And then the other main thing is just patients not doing their exercises or rehab.
Right.
Do the elderly patients typically go into like a nursing home for their rehab because it's like maybe a more focused and intensive rehab? Is that what you're seeing more of now?
So typically we try to get our patients home.
Okay.
And then there's a few options they can do after that. But we are, across the board in the country, there's less and less use of rehab facilities.
Okay.
It used to be everyone
The standard of care before.
But now I
yes.
see very few coming in.
Right. Maybe in this past year, I've had less than 10 patients have to go to rehab.
Okay.
And a lot of those are we have identified before because they don't have anybody at home. They're elderly. They don't have any family around. So for those reasons, they may have to go. So those we know ahead of time. So we kind of plan for it. But typically, we would like patients to go home, one, because you're more comfortable in your home and,
Yeah.
you're in your own environment, sleeping in your
course.
own bed.
Yeah.
There's less risk of infection because at rehab, people are there for different reasons. You don't want to catch
Yeah.
anything, with
Right.
COVID, flu season, pneumonia, all those things. You don't want to catch that. And we can have the
Understandable.
physical therapists come to your house for the first few weeks.
Yes.
So it's kind of like,
Yes.
rehab. Or you can go to outpatient physical therapy. So if you're a bit younger,
Yep.
you can just go to outpatient therapy 2-3 days after surgery.
And that's better.
Right. And
Yeah.
the reason I tell patients it's better for them, to go home, it forces you to walk more and do more. At rehab, you're kind of just in bed in your room
Oh,
for
so
most of the
true.
day.
Right.
Yeah.
They take you to do physical therapy
Yeah.
maybe like twice a day for like an hour or two, but otherwise you're just in your
Yeah.
bed in your
Yeah.
room,
You're
so you're not
waiting for
walking
stuff.
as much.
No.
At home, you're forced to get up to go to the bathroom. You're forced to
Right.
get up maybe to go into the kitchen.
Yeah, if you're hungry.
Right. And if you're going to go to outpatient therapy, it forces you to get out of your house, get in and out of a
Yes.
car, walk to the therapy place. So those patients tend to recover quicker because they're doing more.
Right. Makes sense.
What's the wait time for driving with a knee and a hip?
So everybody's different with hip and knee replacement. If it's your right side, because most people in this country have an automatic car, I tell people it's whenever they comfortably can switch between the gas and the brake, and they're not taking pain medicine. So whether that's a week, 2 weeks, 3 weeks is up to them.
Individual.
But I have a good number of patients where they drive to their 2-week appointment after surgery to see me, because they feel pretty comfortable and they can move and stuff. And they're not driving long distances, but around the
Yeah.
neighborhood, short distances to physical therapy, they're comfortable with.
Okay.
Two questions that I know the answer to, but I'm going to ask because it comes up all the time. Can I have an MRI after a joint replacement? Of course, yes. But it's amazing.
Right.
A lot of people,
Yeah.
still wonder that because there's metal in there, but it's obviously not magnetic. It's
Right. So typically you can have an MRI. Some patients get a bit of a reaction where if they have a hip or a knee replacement, they feel a bit warm,
yep.
from the MRI, but
Yeah.
you can otherwise safely get one because, like you said, their implants are not magnetized. If they get an MRI of the joint itself, so if you have a knee replacement, they get an MRI, they may not get a clear picture
Sure.
because I tell patients it's like a glare off of the metal, there's artifact. They have technology to try to remove it, but it's not a crystal clear picture. But you can get an MRI of the rest of your body without any issues.
And here's the other question that comes up all the time. I'm going to the dentist. Do I need antibiotics?
So that's another debated question, within the orthopedic world because some literature now shows it's not necessary unless you have certain risk factors. And obviously, if you overuse antibiotics, you can develop resistance and things like that. I typically tell patients, listen, you just have to take a few pills 1 hour before your appointment. It's not a big burden on you.
Right.
Might as well take it. I used to see maybe one patient a year with a knee infection or hip infection because they went to the dentist and we don't know why, but they all say, I went to the dentist a few weeks before, I didn't take anything, and now, my knee just started hurting. So, I say it's better to be safer and just take, you typically have to take 3 or 4 pills 1 hour before your dentist appointment.
Right.
And so, we're happy to do that.
Do you
Before
do that?
any procedure at the dentist?
Right. Because when they clean your teeth, that's the most basic thing that you would do in this is get your teeth cleaned. So anytime they clean your teeth, your gums tend to bleed.
Right.
So any germs or bacteria that live in our mouth, if they get into your blood and they find their way to the metal, can potentially infect it. It's a very, very, very small risk, but
But for the
it's not
sake
worth
of a
taking.
pill.
Right. It's like wearing your seatbelt every time you drive. You're not going to get into an accident.
Yeah. But if you do.
99.9% of the time.
Yeah.
Exactly.
But there's a lot of thought that you don't need it, and I see it go both ways. It's interesting, I see some orthopedists will always recommend it, others don't, and depending on what you read, I think the guidelines I've read most recently say you probably don't need it, but like you said, it's probably a small burden to take a couple antibiotic tabs.
Because you don't have to be on it for a week or two. It's
No,
just
you're
a
right,
one-time thing. So, we do that.
But would you be more inclined to do that with like a fresh replacement, or more just you do it for everyone regardless of time frame?
So I do it for everyone regardless of time frame, but I tell patients you can't have any dental work at least 4 weeks before surgery in case you get an infection or
That makes
something,
sense.
and then for 3 months after.
Yeah.
Okay.
Because as everything is still healing around your hip and knee, there's more bleeding and stuff involved and a higher risk for infection. So we just want to wait till your hip or knee is good. So if you have to do anything, get it done now or just push it off for a few months after
But
surgery.
it is still controversial.
It is,
Yeah.
yes.
Chris, when one of your patients is like complaining about knee pain, like at what point, like what criteria do you use for like the different levels of referrals till you get to like the orthopedic surgery?
Yeah, well, I initiate the workup myself, right? And
Okay.
osteoarthritis is pretty easy to sort out, but there's other things that can cause knee pain,
Okay.
tendinitis, et cetera. So, if I feel an x-ray is necessary and I do that, it gives me some sense of how bad the joint looks. But I've always tried, I will have tried other things, anti-inflammatories, Tylenol. I try to stay away from opioids for joint issues like that because it just seems like there's no real good endpoint to the use, unless it's an acute injury. That's a little different. But chronic knee pain has been building for some period of time, or hip pain, I would try that. And then, that's about what I can do. Then after that, if you're, say it's a knee issue and you're looking at, an injection or whatnot, I don't really do that. So I would send someone to an orthopedist and they would evaluate them further, and maybe they would benefit from some temporizing measure such as an injection. But, if it's bad arthritis down the road, as Dr. Patel said, they're probably, they'll know if they need something when the pain gets to that level. But we always try the non-surgical things first.
Right.
Right, and I, do the same. So if they haven't tried anything, we, try everything before we decide surgery is an option.
Yeah.
Do injections work like a lot of the time? Or does it really just depend on
It depends
what
on the
phase
level of
they're at?
arthritis you have, what phase they're at. If you have mild to moderate arthritis, it works well.
Okay.
If you have severe bone-on-bone arthritis,
Yeah.
it may help you for a month or two, but typically not
Yeah.
because you're past that point.
Isn't it amazing, though, how some people have really severe arthritis and have, minimal symptoms, and you have patients who come in with more mild arthritis and they have really bad symptoms?
Yes, and
it's fascinating to
It's
me.
one of the things that we don't understand why. And the other thing we don't understand why is you can have severe arthritis and then one day you'll just wake up and your knee will start hurting you. And patients are like, I didn't fall, I didn't get hurt, I just woke up and my knee's been hurting since then. And other people, they have a fall and then that triggers their arthritis pain. But other people, they just get up off the couch one day and they're like, my hip just started hurting me or my knee just started hurting me. It's like, for example, the car, you have to change your tires every 20,000 miles because it may, wear out or pop or, but you don't know if it's 20,001 mile, 20,100 miles or,
Sure.
25,000. So
It
same
reaches
with the
some critical
arthritis.
point.
Right.
Yeah.
And that's different for everybody.
Yeah.
Does the recovery period differ depending on the reason why you're getting the surgery done? Like, suppose someone gets in a car accident and they need a knee replacement, or they have arthritis and they're getting a knee replacement. Does that affect their recovery time?
Typically not. With arthritis, for example, and there's like rheumatoid arthritis and other things, recovery time is more or less the same. But if you take certain medications, like for your rheumatoid arthritis, that slows down skin healing.
Yeah.
So that may, take a bit longer. If you have a fracture and you need surgery for that, bone healing can take 2 to 3 months on its own. So there's other factors that can play into it.
So suppose I have a little vovô living with me. For the non-Portuguese people out there, that's like a little Portuguese grandmother. And she wears a knee brace. And she's like, nope, I'm good. I have a knee brace. So when people try to, like, I guess, put off anything invasive, can she wear the knee brace forever if that's what does it for? Or are you like, you should really kind of get it checked out a little bit? Like, we know the knee brace is
She's doing well with
helping,
it. She
but
doesn't have a lot of symptoms. Then
go for it.
Yeah, just stay with what you're doing.
Right. Yeah, if it's helping. I also tell patients you can wear a brace, but just be careful because your body then relies on the brace instead of your own muscle, so it
Lose
can
some
weaken them.
musculature.
Right. So it's, as long as you're keeping up with your activity level
Yeah.
or
Yeah.
exercises, you can use the brace.
Yeah.
In younger patients, they wear the brace at work, but then after that they don't
Yeah.
use it. Or when they play sports, they wear it, then they don't use it. So you don't want to get too dependent on that. But
Okay.
a brace can certainly help. And we recommend, depending on the patient, before surgery, if one of the things they want to try is potentially a brace that can help aid.
Now, I understand there's a couple of different types of hip replacements. Can you talk about the differences with the different types of hip replacements?
Yes, so with hip replacements, it has to do with the approach, like how you get into the hip joint. Traditionally, most orthopedic surgeons used to do what's called the posterior approach. So they go through the back way to your hip. So they have to go through your glute muscles and your external rotator muscles to access the hip joint.
Okay.
And that has worked. And
Okay.
you get, good results from it. And then over the last several decades, there have been other approaches. Well, someone's like, well, what if we try to go through the front where we don't have to cut the muscles?
Right.
And, so that has become popular. In 2010, for example, anterior hip replacement, which is what I do, where we don't cut any of the muscles, it was only done by about 5%
Wow.
of patients. Now, 10, 15 years later, more than half of hip surgeons are doing anterior hip replacement. So it's shifting because, one, they're getting more comfortable with it. They're getting trained on it. Two is they're seeing the benefit of it, where you don't have to cut through the muscle because when you go from the front, there's less restrictions
Yes.
for the patients versus if you go to the back, traditionally you have to sleep with a pillow between your legs for the first 3
Yes.
months. You can't cross your legs, things like that. But with your hip replacement from the front, you don't really have any of those restrictions. So for the patient, it makes a bigger difference versus for the surgeon itself.
Probably less painful, too, for the patients, right?
Right. And, hip replacements from the back have a higher risk of dislocation compared to from the front.
Yeah.
Hip replacement from the front does have its own issues, like wound healing complications, especially if you have like a big pannus or a belly that overhangs your hip. So it has some things to be careful of or mindful of as well. But typically, hip replacements from the front do recover quicker, or they get back to activity a bit quicker, or they have a bit less pain and swelling because the muscles weren't cut; they were just spread and then put back into place after.
I mean, it seems like when patients go to a surgeon and surgery is recommended, they should be asking questions about how the procedure is done.
Right.
Do you find patients do that, though? I would think that they probably don't as much as...
They should. Yeah, so not everybody does. I
Yeah.
would say more than half probably don't. But I always tell patients, because it's better to pick your surgeon than pick the surgery.
Yeah.
So, for example, if you come to me, for example, and you say you want a hip replacement, done from the side, I don't do that. And I don't want to watch a video and try it on you. So I would say, maybe go to somebody else. But
Yeah, right.
if you want me to do your hip replacement, I'm great from the front or from the back, So I'm happy to do it that way. So it's more of picking your surgeon and who you're comfortable with
Right.
and, who you think will do a good job or is
Right.
experienced or you've heard good feedback about
Sure.
than the actual procedure. Same with the knee, as well,
Makes sense.
or in any surgery for that matter.
What are the most common complications that you see with hip or knee surgeries?
Number one would be, so complications would be that we worry about is infection.
Yeah.
With hips, it's dislocation, but I do mine from the front, and knock on wood, I haven't had any in a few years at least.
Sounds
So,
like a terribly painful thing.
right, yes, yeah.
What do you do for a dislocation?
You have to go to the emergency room. They try to put you to sleep, and they try to put it back in. If they're not successful, we have to take you to the operating room and then do it that way as well. So it's not fun for anybody, but
Why does it pop out?
it could, one, be the way it was put in. It
Okay.
may not be secure, or if you have precautions and you don't, or you aren't mindful of them and you do something
Yeah.
you're not supposed to, it can come out that way as
Yeah.
well. Or, you could have a fall and it could just all of a sudden just come out.
Okay. Okay.
So it's a few reasons.
When it
Okay.
dislocates, does it damage the joint itself, the artificial joint?
Typically not, but if it's a recurrent dislocation over time, like many times, or it just even partially comes out and it goes right back in, it can wear and cause damage.
Okay.
What are the other complications? So you said like infection, the dislocation.
Right. Wound healing complications, so like smokers, things like that.
Okay.
Blood clots, is a, and these are all small
Yeah.
numbers, but, blood clots is another one. So we give everyone a blood thinner, whether it's a baby aspirin or something else, depending on
Yeah.
their medical history, to
Okay.
take for, several weeks after surgery.
Okay.
Stiffness and pain. So if you don't start moving right away or do your exercises, you're going to stiffen up, and you might
So
be
like
left with
immobility.
pain and stiffness. Yeah. So lack
Yeah.
of mobility is another one.
Okay.
Fracture is another one. You're cutting the bone, you're putting in metal, things can always break.
Yeah.
It's very rare, but it can potentially happen
Right.
as well.
Okay. All right. Oh boy.
What's interesting about hip arthritis is a lot of patients come to me and I diagnose it and they don't believe it's their hip because they have groin pain. That's how
Right.
they present. Patients always find it interesting that it's in their groin. They always think, well, I have hip problems, it should be
Right.
here, right? And it's not. And the other thing a lot of patients present to me with is just limitation in motion. They can't tie their shoes anymore.
So the number one question I ask anyone that comes to see me with hip pain is, can you point to where your pain is?
Yeah.
And a lot of times they'll just point to their back.
Right.
So it's like, well, that's not your hip.
That's not your hip.
Like you said, they don't know that your hip is actually, in the groin.
Yeah.
And that's where you typically have pain. And that pain can also go down your thigh into their knee. So some people, like my knee also hurts. You
Right.
get x-rays, their knee is fine. It's all coming from the hip. So that can also
It's interesting
happen.
how it presents.
Yes.
It always throws some patients off guard when they hear it's their hip.
Yeah, and sometimes it can also be from your lower back.
Yeah. you're right.
Depending on what level, you have herniated disc or nerve impingement, it can cause pain that goes into the groin.
Exactly.
And so they may think it's their hip, but it's their back.
Sometimes it's
so-
hard to sort out too.
Right, yeah, and we check both.
Yeah, it's interesting. This was great. Very fascinating. Do you have any other questions?
No, but I really like the methodology you use to do your operations
Yeah.
and stuff. It's like I'm hearing that's the least painful, that it's like more cutting edge than
Yeah.
maybe what else is
What
out
was
there.
out there previously? Yeah.
Yeah, so I'm feeling okay if I need like a knee or a hip surgery.
You know where to go now.
I know where to go.
And like you said, our patients do well. Like I've had patients where I've done their knee this way and I've done their knee the old way, and
Yeah.
they say this way was definitely easier, and they do well with the old way, but they're like, this was definitely easier for me to
Yeah.
recover, or less pain or swelling.
Yeah.
And I would say maybe a third of our patients don't take any opioids, so they just take Tylenol after surgery,
Great. Yeah.
along with
that's
some
excellent.
anti-inflammatory medicine, but Tylenol is their main pain medication. Less and less people are using opioids. When I first started, people used to take 2 oxycodone pills every 4 hours after hip or knee replacement because it was that painful.
Right.
Now I would say more than half don't take any.
Yeah.
Maybe they'll take some tramadol, or they're like, I took it maybe for the first day or two because I was a bit nervous or scared, or I took it at bedtime to help me sleep.
Right.
And then we do still have some patients that take it, because I tell patients, if you need the pain medicine, take it, because I'd rather you would take it and be able to do the rehab and
Yes.
physical therapy than just sit there in pain and say, I'm not, going to take the medicine. But
Right.
patients are surprised at how little pain they do have after surgery this way.
Because that was like my concern. It's like, okay, I guess I need this. Like, what am I in for? You know,
Right.
is it going to be super painful? Like, how long am I going to be laid up for? When can I get back to my like regular activity? You know, and just sounds good. I'm okay with it.
And patients always ask, like, when can I walk after surgery? So I say the same day.
Nice.
Because we want physical therapy to see you, try to get you out of bed,
Yeah.
get you moving, because that's the goal of this surgery, is to try to get you up and active and back to your life, back to being mobile.
Okay.
Is there one message you'd like to leave patients or anyone listening to this about, who may be requiring knee or hip replacement?
Definitely. And from what patients tell me, one is it's not as bad as you think it's going to be.
Okay.
And, everyone has a friend who had a surgery and it went terribly wrong, but that's the minority.
Right.
Vast majority of patients do very well. And even if you're nervous or hesitant, come in, have a conversation, or, and then you can decide, what your goals are, how comfortable you feel, things like that. And for that reason, I asked certain patients if they're willing to, if they would do like a 15-second video clip or, just to talk about their recovery. And then so we
Nice.
post it on our Facebook. And then other patients see it and they're like, well, he's just like me or she's just like me. And if they
Yes.
could do it, I could do it.
Such a good idea.
So it helps them get that confidence
Yeah.
because hearing is one thing, but then seeing it is
And
another
seem
thing.
like a normal person, not like a
Right.
model or something.
Yeah.
Like, just show me Joe Schmo from down the street, and
Right,
if he's
right,
doing
right.
okay, I can do okay.
Exactly.
Yeah.
I love that. That's so
And,
smart.
You may have a friend circle that all might need knee replacement. And they see you
Yeah.
and they're like, wow, she's doing so well. It's not
Yeah.
that bad at all. So maybe I'll consider it then,
Right.
So it helps give people the confidence and the courage to
Right.
do it.
Nice.
Well, Dr. Patel, thank you so much for coming on to the show and talking about knee and hip replacement. I thought it was really interesting because these are newer procedures that a lot of us don't really know about. And it's nice to know that there's so much new technology out there
Right. And advancements.
and how it's helping patients in recovery. So I want to thank everyone for listening to our show. Hopefully I'll keep my voice through this part.
I was just going to ask you if you wanted me to do it, so you
No,
don't
it's
have to
okay.
talk.
I'm all right. If you'd like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music. Primacare, your trusted medical providers in southeastern New England, and the BioSkills of Northeast for producing our show and available to produce your show by calling 774-301-8811. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. Thanks again, everyone, for watching our show. And Dr. Patel, thanks again.
Thank
It was
you.
great.
Thank you
really
for having me.
appreciate you coming down here. We enjoyed it.
Anytime.